First of all, we will start with the shoulder dislocation, which I'd say is the most frequently encountered dislocation. I won't go much into the lecture part because you just had that earlier, but there are anterior dislocations, posterior dislocations, inferior dislocations, and 97% of them are anterior dislocations. This shoulder, not this shoulder dislocation, but any type of dislocation represents an emergency, an orthopedic emergency. It's one of the biggest emergency we have in orthopedics. So you need to reduce the dislocation as soon as possible. And so we are at the ER room, and we have the patient coming in the room, or either coming on his own feet or brought by the emergency personnel. And what you see is the fact that the first thing you see about this patient is that he kind of places his healthy hand on his elbow, trying to sustain his injured arm, which is called a humble position.
Excuse me, doctor?
Yes?
I don't know if we're supposed to see them, but we're on slide 21.
Okay. Just a second. So you're not on.
Okay, now it's on the slide 1.
Okay, must have. You see it? Wait, just a second. Is it now on the first slide?
Yeah.
Okay. Now this is like a general presentation. I won't have pictures for the reduction maneuvers, but I'm kind of making like an introduction for you, because we're technically on the practical side, so we need to see how we treat the patient from the beginning till the end, even though my micro lecture is just about the reduction maneuver. Okay, so as I said, the patient's coming in, he's in the humble position, trying to sustain his injured arm with his other healthy arm. When you look at him, you will see that the shoulders are asymmetrical, like there is a gap on the injured shoulder side, because the humeral head is not there anymore. When you palpate that shoulder, this should have been told to you on the lecture also. When you palpate the shoulder, you will see that there is an actual gap where the articulation should have been, because as I said, the humeral head is not there anymore. While on the other side, there is you can palpate the humeral head, so you can't go any further with your hand, which makes you think it's a dislocation. You send the patient, after that you send the patient to the x-ray. You take an x-ray of the joint. You need to do an anterior view, but also a lateral view to be sure that it's dislocated. You confirm your suspicion, and after that you need to, as I said, reduce it as soon as possible. Now there are a certain number of reduction maneuvers. We will talk about all of them, because there are these are subjects for your practical exam. Just a second, because my boss is calling, which is not good. One moment. Sorry about this. I'm back. Is the slide okay now? By the way, like you see the reduction worn out slide. Yes.
No, it's on slide 1, shoulder dislocations. Okay, now it's good.
Okay, now it's back on the first one. Yes. Or
It's on the second one, the von Arlt.
But is it like full screen, or you see the non-full screen version?
Non-full screen version.
Oh, okay, that's the problem then. Just a second, because I think I know how to fix this. 1 second, because I think I maximized it after I did the presentation, which made me not, yeah, that's the problem. Yeah. No, there we go. There we go. And now it should, you can see the switching, yeah?
Yeah.
Okay, that's fine. So, as I said, multiple reduction maneuvers, we will take them one by one. The first one is the von Arlt reduction, which is my personal favorite, and I'd say the less traumatizing for the patient. Again, this is done at the ER room with either local anesthesia or an IV anesthesia. So if you know, there's general anesthesia, there's local anesthesia, there's Rahi anesthesia, but there's also an IV anesthesia when you actually inject some anesthetic IV to the patient, which makes him a bit more relaxed than when you are awake, like kind of a semi-sleeping mood. So, because the fact that you need to reduce it as early as possible makes you want to do it in the ER room and not wait until you admit the patient in the hospital, look for an operating room, bring the patient to the operating room, etc. So you want to do it as fast as possible. So, as I said, this is done at the ER room. With the von Arlt maneuver, you will need a chair, as you can see in the picture here, a chair with a back, so it needs to have a support. On this support, you need to place a cushion, a pillow, something soft, a soft material, because as you can see, you will place the axilla of the patient on this chair support, on the chair's back, basically. And your arms, this is the examiner here, your arms will be placed one on the elbow and one on the actual hand of the patient. And what you do, the general rule here for each of the reduction techniques is that you need to do traction. So this is not just for this one, this is for every reduction maneuver. You need to do traction in the arms direction. Why do we need to do this? Because the muscles are contracted, either because of the pain, either because the patient is scared, and all sorts of other reasons. And this muscle contraction prevents you, or doesn't allow you to reduce the dislocation. So you need to keep this traction so you can actually loosen the muscles. By keeping this traction, the muscles will eventually loosen themselves, and so you will actually be able to do your maneuver, because the humeral head will start slowly moving backwards to its place. And at this point, when you feel that, because you have your hand on the patient's elbow, you will do external rotation with your other hand, as shown in the picture here, so that you keep the traction. When you feel that your arm is lowering more because of the fact that the humeral head moves back to its place, you need to do external rotation. And you will hear a click, which means that the click signalizes that you reduced the dislocation. So that's one maneuver. The other maneuver is the Hippocrates maneuver. You have now the patient lying on the examining bed. You place both your hands on the patient's wrist. You need to do a 30 degrees abduction of the patient's arm, and you place your foot in the axilla of the patient. So this time around, instead of having the chair doing the counter, you need your own foot placed in the axilla of the patient, acting as a counter. And again, the same principle, you do traction in the arms direction, waiting for the muscles to tire. When you feel that your arm, the patient's arm is moving towards you, it means again that the muscles relaxed and the humeral head started moving backwards to its place. You need to do adduction, so you basically lower the angle, so you bring the arm towards the torso of the patient, adduction. And again, you hear the click. The next maneuver, which is the Mott maneuver, this is a more complicated maneuver because of the fact that it implies one or two helpers. Again, the rate of complications here is higher, so you can actually cause a fracture of the humerus if you don't do it properly here with this maneuver. So it's less used than the other ones, and it's also, as I said, more elaborate and more complicated. What do you need? You need one helper, as seen here, placing a cloth or anything soft through the axilla of the patient, acting as the counter, pulling it in the opposite direction. You need a second helper on the other side of the patient, trying to palpate the humeral head, and then the person that's actually not shown in this picture is the actual examiner, the doctor, who will stay on this side here next to the second helper, grabbing the patient's arm and doing the actual reduction maneuver. So as I said, you need 3 persons, 2 or 3, because the person that can be removed from this equation can be this one here, the person that keeps the cloth, because you can have the cloth like hang to the wall or something instead of having the person pulling it. But you still need a certain amount of preparation to do this maneuver. And the examiner, again, as on the previous maneuver, places his hands, both his hands on the patient's wrist. The patient's arm will be in a 90 degrees abduction. So basically, this picture here shows you the end of the maneuver. But the beginning of the maneuver is when the patient's arm is in 90 degrees abduction. And it goes from there. So the examiner does traction. As I said, every reduction maneuver needs traction. Does traction in the arms direction. The helper who palpates the humeral head will signal the examiner when it starts moving, at which point the examiner does intensifies the abduction, so brings the arm upwards, well, 100 degrees abduction, at which point you should hear the click, and after that he just lowers the hand below near the body, as you see in the picture here. This is the final position of the arm. So you start in a 90 degrees abduction, you go to 180 degrees abduction, and then you just lower the arm of the patient in its normal position beside his or her body. Okay. And the last method for the shoulder dislocation is the Kocher method. Again, not that much used because of the fact that you can cause, as you can see here, this position here can cause a fracture of the humeral neck. And again, it's a bit more complicated because, as you can see here, it's composed of 4 steps, this Kocher method. All these 4 steps together form the Kocher method. By this, I'm trying to say that these are not individual steps, they are chained one to another. So you need to go from one to the other without pausing. And if you do it properly, you will reduce your shoulder dislocation. And that's called the Kocher method. So the patient, again, lying on the examining bed, you have your hands, one placed on the elbow this time and one placed on the wrist, like on the first maneuver on the von Arlt. As you can see here, also one on the elbow, one on the wrist. And we will take them one by one, the steps. So the first step, as always, the traction. So you have traction in the arms direction. and you keep the traction. When you feel like, again, the arm is moving towards you, you will do external rotation with adduction, yeah. Then you bring the elbow forward, as you can see here. So examiner tries to bring the elbow forward and then does the other side. Is when you're keeping the traction, there's then benefits. You can try and panic the patient. He can have a muscle contraction and etc., and fail the maneuver can cause complications. So again, traction, external rotation, then adduction with bringing the arm forward, the elbow basically forward, and then internal rotation, placing the hand on the shoulder on the other side. Okay, after you do your reduction, you send the patient again. Whatever reduction you do, doesn't matter. You always need to send after this maneuver, you need to send the patient back to X-ray so you can see that you did it properly, didn't cause any complication. And after that, you need to immobilize the dislocation. How do you do this? You use the Dessau bandage. Now, there are certain types of Dessau bandage, but the one we use is with bandages. So you have the patient either standing, either sitting on the bed. The arm itself is placed in adduction and internal rotation, as you can see. The first thing you need to do is protect the skin, because of the fact that you will need to immobilize for long duration of time the arm. You need to actually be certain that there are no skin lesions whilst the arm is immobilized. So the first thing you need to do is place cotton bandages in between the arm and the torso of the patient, also in between the forearm and torso of the patient, but also under the tits if it's a one, because the bandage will press, as you can see here, the bandage presses on the chest of the patient. See, cotton, and no cotton here because it's not a woman. After you place these cotton bandages, you start actually doing the actual bandage itself. And there are three directions in which you go with this bandage. So the first one is around the torso, as you can see here, with the injured arm, but above the forearm. The second direction is, say this again, around the torso, but below the forearm, so you can actually sustain the upper limb, as it said, as it's written here. And the third direction is in the arm's direction, so you actually place the shoulder also in your bandage. After you do this initial three directions, you repeat the process multiple times until you feel that it's thick enough to support the patient's forearm, at which point you reinforce with tapes, as you can see in the picture here. And this is the final version of the bandage. As I said, because of the fact that you need to keep this in total of 3 weeks, you need to have the patient hold for checkups. These checkups need to happen weekly for two reasons. One, because of the fact that the patient breathes. the bandage will loosen itself, which means that it will require changing at a certain point. But also for hygiene measures, because of the fact that the shoulder of the patient is actually under the bandage, so he can't bathe it. So when you change the bandage, there is a very good opportunity for the patient to actually do some local hygiene on the axilla, on the shoulder spot here, before you place the next bandage. Why we don't keep the bandage more than 3 weeks? Because of the elbow. The elbow, placing the elbow or the knee more than 3 weeks in any kind of immobilization can cause stiffness. So this is the reason why we keep only 3 weeks the bandage. Also, when you call the patient for checkups, besides the fact that you will change the bandage, you will have also, it's a good opportunity to x-rays, see that everything is in order with your reduction. Moving on to elbow dislocations. Elbow dislocations, again, there are two types. There can be posterior lateral, posterior medial dislocations. Wide, they also can be anterior, but that's very, 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 very low rate because of the fact that the triceps muscle inserts itself on the tip of the cranium, and usually it will, when there's a trauma happening, the triceps will do a big contraction and it will pull the olecranium backwards and posterior, so dislocating the elbow posterior in 99% of the times. Again, ER room, patients coming in, again, he has that humble position when he's trying to support his elbow with his other hand. When you look at the patient, you see there's swelling at the elbow region, which starts you into trying to check that certain articulation. Upon examiner places one hand on the elbow, trying to palpate the olecranium tip, and the other arm of the examiner is placed on the wrist. And what you need to do is basically try to, with your finger that palpates the olecranium, try to do traction in the direction of the arm. So you need to do a traction distally of the arm, trying to lower the tip of the olecranium and also the coronoid process to lower it below the humerus. So then after that, you can actually do your traction in the forearms direction with your other hand. So you reduce the dislocation, right? So you have traction in the direction of the humerus, then traction in the direction of the forearm, and sometimes, but not depending on how your x-ray looks, because it can be a bigger dislocation. Like the more dislocated it is, the more maneuvers you need to do. So you need, if you can actually, you can add, besides these two maneuvers, the internal rotation if it's a posterior lateral dislocation, or the external rotation if it's a posterior medial dislocation. So traction, traction, external rotation. The other way to do it is with the patient lying on his front on the examining bed, with the elbow on the edge of the bed, as you can see here. So basically the examining bed is the actual counter here. See, so the arm is at the edge of the bed. But it's the same principle. As you can see, you palpate with one hand the olecranium, you place one hand on the wrist. Try to do, as you can see, traction first on the arms direction, then traction on the forearms direction, with adding the external or internal rotation if it's needed. After you reduce, send the patient to the X-ray, confirm your reduction, and after that, we immobilize the cast above the elbow, obviously, for 2 to 3 weeks. Why do I say 2 to 3 weeks? You can, if it's a young patient, active young patient, you can keep the immobilization for 3 weeks. But if it's an elder patient who can be susceptible to stiffness sooner than a young, active, regular person, you can actually take off the immobilization sooner, so on at 2 weeks, so you don't risk stiffness of the elbow. Just 1 second. Moving on to hip dislocations. Now, I won't go much in the lecture material what you did earlier, but there are 4 types of hip dislocations. There can be posterior superior, posterior inferior, then anterior superior, anterior inferior. So there are 4 types of hip dislocations. The most frequently one is the posterior superior one. Again, I think this was told at the lecture. Why is it the most frequently encountered? Because of the fact that the traumatizing agent is usually during a car accident, with the patient, the passenger on the front right, hitting the dashboard, and so dislocating his hip. The posterior. Also, the frequency in which we see this dislocation has intensified in the last, I'd say, 5 years, meaning that it actually quadrupled or something like that. So our more experienced and older doctors say that they have not seen as many hip dislocations as the residents in this hospital have seen in the 5 years they do practice here. So, and this is caused by the fact that more and more persons have cars. So that's why these dislocations grow in frequency. Okay, now moving back to our stuff, our material. You have the patient again. This time around, he's not coming in the ER. He's actually being brought on a stretcher or something on the ER. There is a certain position each of these 4 dislocations has when you look at the patient. In the case of the posterior superior dislocation, you will see that the leg itself is internally rotated. It's shorter than the other one, and it has a certain degree of adduction. So it's trying to go over the other leg. So again, it's very hard for me to make you imagine. There should be in your lecture, and there should be in your books, the picture is what I'm talking about. So when you look at the patient, each of these 4 dislocations has its own clinic view. So you will think that there is a shoulder dislocation. You send the patient to the X-ray. You do an anterior view of the articulation, and you need to do the reduction. This time around, because it's the hip, the muscles here are bigger, stronger, and the contraction is stronger. You can't do your reduction in the emergency room. You need to do this in the operating room. So the hip dislocation 100% is reduced at the operating room. Why? Because you need to counter this muscle contracture, and the only way to do this fully is by general anesthesia or rack anesthesia, and this needs to be done at the operating room. So you need to get the patient as fast as you can in the operating room if there is a hip dislocation. Okay, so you have the patient on the operating table, you have your anesthesia, and now you need to start doing your reduction. How do you do this? You have 2 ways of doing this. The first one is the patient lying on its back. It's called the Alice method. You need to have one helper placing his hands on the pubis of the patient as a counter, while the examiner with both his hands on the knee of the patient does 90 degrees flexion of the calf and 90 degrees of the thigh, and does first of all traction in the femur direction, and when he feels like the femur is coming towards him, as you can see, this is posterior dislocation here. See, so this is what they're trying to exemplify. This is the posterior dislocation. We have the helper doing the counter. You have the examiner doing traction. As you can see, the arrow here. This helper is not needed because if you have total muscle relaxation, you will be able to do this on your own. But to make my point, you need to have traction, and as I said, when you feel like the femur is starting to move back to its place, you need to do either external or internal rotation depending on what type of dislocation you have. In our case, since it's, as I said, you have a posterior superior one, which I said earlier means it has internal rotation as the pathological clinic sign, you need to do external rotation. So you need to do the other direction of the dislocation to reduce it. So exactly the opposite of this arrow here. You need to do external rotation. The second way of doing this with the patient lying on his front on the table, with the pubis at the edge of the table, you have again the helper trying to palpate the femoral head, while the examiner with one hand on the knee does the traction in the femur's direction, and when with the other arm placed on the ankle of the patient does again external or internal rotation depending on which direction it needs to go, depending on which type of dislocation he has. And also when the helper palpating the femoral head tells that the actual femoral head starts moving back to its regular joint place. After the reduction, you need to have an X-ray. This is done usually with mobile X-ray machine, which we have in our operating rooms, so you can confirm your reduction. Since it's the hip, you can't do a cast because you don't have anything proximal to the hip, or well, you have, but you can't mobilize. And so after this, you need to, what we do here, to immobilize the leg. We do space. Condyle traction, but this is the only picture that was but traction, the skeletal traction, which means see what I'm trying to explain. So you have a spine which is very brown, so the upper of the femoral means that traction picture. So you place easy to the traction. You place support on the actual action contained keep so it keeps good as you to be that can be mobilization of even if it's 3 weeks, 4 weeks, 6 weeks, 2 weeks sometimes, depends. After you take it off, you allow patients to do partial weight bearing, so basically placing his lower limb on the ground but not putting weight on it. The weight will be added gradually in the next 2 to 3 weeks until the patient feels comfortable enough to place his whole weight on his injured limb. Okay, I think that's all. Yeah. If there are any questions or problems or issues or other stuff. If not, then we will see each other, I think, later, because I think some people will come to the clinic. Thank you for being here and paying attention, and have a great weekend.
You too. Thanks a lot.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.